Hello and welcome to a new webinar from Pulse Telehealth Resource Center, Telehealth Access Points 101. What are TAPs and why do they matter in rural healthcare? Pulse Telehealth Resource Center, or Pulse TRC, is part of a HRSA-funded consortium of 12 regional and 2 national telehealth resource centers, providing free, federally funded telehealth education, resources, and up to 10 hours of technical assistance for clinicians and community organizations. Pulse TRC's region includes Kansas, Oklahoma, and Missouri. We offer unbiased, research-based best practices to help providers connect with patients in new and innovative ways. Our presenter today is Samuel Karns. Samuel is a rural and telehealth specialist with Oklahoma Complete Health, dedicated to improving healthcare access for rural and underserved populations. His work focuses on leveraging telehealth and community-based strategies to address provider shortages, transportation challenges, and digital access barriers. Through collaboration with the Pulse Telehealth Resource Center, he has helped raise awareness of telehealth access points and their potential to improve access to care across Missouri, Kansas, and Oklahoma. Samuel is honored to serve on the Pulse TRC Advisory Board and looks forward to helping advance telehealth solutions that connect more people to the care they need, regardless of where they live. And I'll hand it to you, Samuel.
Good morning, everyone, and thank you for taking your time out of your schedules to join this presentation. Today I'll be talking about telehealth access points, what they are and why they matter, and how they can be used to reduce barriers to care, especially in rural and low-income communities. My name is Samuel Karns, and I serve as the Rural and Telehealth Specialist for Oklahoma Complete Health. In that role, I support rural health initiatives, telehealth implementation, provider partnership, and large-scale projects designed to improve access to care across Oklahoma. Before working in healthcare, I worked at the Oklahoma Broadband Office, where I contributed to the state's digital equity plan and 5-year action plan. I also worked at the Oklahoma Department of Libraries, where I helped roll out 5 telehealth access points in rural and underserved areas. The reason I'm excited to talk about this today is twofold. One is that I have a lot of family in rural areas. I spend a lot of time in rural areas. I grew up in Watonga. It's a small community. And I'm just really passionate about trying to get healthcare out to those people. The other reason I'm excited to talk about this is because telehealth access points, sort of sit at this intersection of several issues that we're all trying to solve. There's healthcare access, broadband access, digital literacy, transportation, privacy, and community partnerships all play a part. And in those rural communities, those issues don't exist in isolation. They stack on top of each other, and when they do, they create real barriers for patients who are trying to get basic and timely care. So to frame this conversation, I wanted to briefly connect telehealth access points to the mission of Oklahoma Complete Health. Our purpose is transforming the health of the community one person at a time. Our mission is better health outcomes at lower costs, and our work is grounded in a whole health, focus on the individual and heavy, active local involvement. I wanted to bring up Oklahoma Complete Health mainly because we've got partner plans in other states that would be happy to partner on for any sort of program like this. If you need connections, we can reach out to them for you, get that set up. And I also wanted to point out that while I'll be using a lot of Oklahoma examples today, the model's not limited to Oklahoma. Many states have similar health plans, community organizations, libraries, schools, broadband offices, healthcare providers. All of those that can partner on a rural health initiative. So as we go through this, I encourage you to think about who the equivalent partners might be in your own state or region. All right, so what exactly is a telehealth access point? At its simplest, it's a private, clean, connected space where someone can complete a telehealth visit with the support they need. That space could be a dedicated booth, a retrofitted room, a school-based site, a library, school, a clinic-adjacent space, or another community-based location. The form can vary quite a bit depending on the setting, but the core attributes are fairly consistent. Ideally, a telehealth access point is going to be ADA compliant. It will have room for a caregiver, includes strong connectivity, provides privacy, and is supported by trained staff or digital navigators who can help users access care. Some sites also include remote diagnostic equipment, although the extent of that equipment depends on the funding, site capacity, and provider partnerships. That's a big one. A lot of different providers may prefer different equipment or software. Um, so that depending on your provider partner, your program could look significantly different. The other component, the digital navigator component, is especially important too. We often talk about telehealth as if the only requirement is an internet connection, but that's not true for most patients, or many patients. Patients may need help logging into a portal, using a video platform, entering an email address, adjusting camera and microphone settings, or understanding what to expect during a virtual visit. If we don't account for that support, the telehealth visit can fail before the provider ever joins the call. So when I use the phrase telehealth access point, I'm not just talking about a room with a computer. I'm talking about a flexible, scalable model that combines space, privacy, connectivity, equipment, support, and local partnerships. The equipment can vary based on the type of site and the level of clinical support being offered. At a minimum, the site needs a reliable computer, a high-quality camera, speakers or headphones with a microphone, strong internet service, adequate lighting, and some basic diagnostic tools. Examples of basic diagnostic equipment are going to be like a pulse oximeter, blood pressure cuff, thermometer, or a scale. Some sites, including some of the ones we've rolled out, choose to go further. They may include multiple screens, advanced audio or video technology. Some have more complex remote diagnostic tools. But the most important thing is that the equipment needs to support a smooth, professional telehealth visit. Poor audio, poor video, or unstable internet can quickly undermine the confidence in the entire model. So for patients who may already feel uncertain about telehealth, the experience matters. If their first visit is frustrating, if they can't hear the provider, if the connection drops, or if they feel embarrassed because they don't know how to use the technology, they may not want to try again. So the equipment it's not a technical consideration, it's part of the patient experience. Privacy is one of the biggest concerns that comes up when discussing telehealth access points. In rural communities, people often know each other, and there can be a real concern that others may overhear sensitive health information. That means we have to think beyond basic HIPAA compliance. We also have to think about whether the patient feels comfortable using that space too. And there's several ways to address this. Some booths come with soundproofing panels already installed. Existing rooms can be modified with acoustic foam, and white noise machines can be used to further muffle the sound outside the room. These are relatively practical additions that can make a big difference in perceived privacy. They're also really cheap options too. For the amount you'll spend on those, there's a lot of comfort that it brings the patient. Definitely recommend them. Privacy also applies to technology as well. So computers should be set up with appropriate firewalls. They should wipe users' data between visits. Examples listed in the slides include, things such as deep freeze, Google admin, reboot, restore. Some of those are ones that we've used in the library in the past, and they've been effective. So the goal is to make sure that no personal information remains on the device after the visit's completed. If people don't trust the privacy of the space, they're not going to use it for sensitive appointments. And for many telehealth use cases, including behavioral health, chronic disease management, specialty care, privacy is non-negotiable. So another major concern is always sanitization. These spaces, are used by people who are sick, immunocompromised, the elderly, medically vulnerable. So the cleaning process needs to be simple, reliable, and then easy for partner sites to maintain. There's a few options here that I put in the slides that are effective and we've used in the past. There's also some other ones that we could dig into at a later time. If you need to, feel free to reach out. So HEPA filters, that very common. They're used a lot in medical facilities, but they're going to passively clean the air in the room. Those should be standard in a small space like that. They're going to be very effective at cleaning out the air. UVC lighting is another thing that we started utilizing in these. These are either going to be standalone lamps or replacement bulbs for existing lighting. But this is going to clean the surfaces in the room while the patient's no longer in there. So in between visits, you can get a fairly effective clean just from running the HEPA filter and the UVC lighting. And then another thing I always recommend are electrostatic sprayers. So they can be used to quickly disinfect equipment and surfaces. And you can see here, so the electrostatics player much faster. It's going to take 20 seconds to clean a wheelchair versus the 84 seconds for a traditional wipe down. So in a small space like this, it's very quick clean, and it just helps reduce the barrier of taking too much time. These are already going to require some labor on the part of the partner sites, and so this just helps reduce that. The important part is the partner sites need a sanitization process that doesn't create an unreasonable burden. If a small rural library or school already has limited staff, you can't design a model that requires complicated cleaning procedures after every visit. But still, there's sick people coming in and out. It has to be effective. So the process has to be effective, but it also has to be realistic. So telehealth access points can take many different forms. Some examples, there's libraries, there's school-based telehealth, community health centers, FQHCs, rural health clinics, hospitals, or health system satellite clinics, retail clinics, EMS-based telehealth. There's quite a few Veterans Administration sites now, and then also I like to lump in hybrid clinics as well. We're starting to see those much more, and they allow it's just a cheaper model in that you have more reliance on telehealth, more utilization of regional floaters. So you may have fewer numbers of providers at a particular location, but they may travel in a region and then rely on telehealth in between. In some locations, the model is going to be very simple. It's going to be a private room with a computer, strong connectivity, and trained staff to support. And other locations, it's going to be a dedicated booth. And that may be necessary because the site does not have a private space already, but they may have an open space where they can put one of these booths. Some healthcare settings may use just carts that they roll around from room to room, or there's cabinets with all the diagnostic equipment included in them. The model should follow the need, the space, and the partners involved. The flexibility of this model is one of its strengths. So Telehealth Access Point doesn't have to look the same in every community, and it really shouldn't. Rural schools, tribal communities, libraries, health centers, EMS sites, and community centers all have different strengths and limitations. And the best implementation is the one that fits the local environment. So now that we've defined what a telehealth access point is, let's talk about why there is a need. So the barriers facing rural communities are often overlapping. The slide visualizes this through a Venn diagram that includes affordability, lack of affordability, transportation, privacy, physical options, digital literacy, and connectivity. For many rural communities, the issue is not just that one barrier exists. It's going to be that several barriers exist all at once and overlap. A patient may live far from a provider. They may lack reliable transportation. They may also have poor home internet. And then on top of that, they may not have a private space to complete a visit. With all those things, even there's still the consideration that they may not feel uncomfortable using digital tools. So any one of those barriers can prevent access, but when they stick together, they create serious isolation. And this isn't really just about healthcare. These same barriers affect education, employment, public benefits, social connection, and just an overall quality of life. But healthcare is where the consequences become especially urgent. Delayed care leads to worse outcomes, higher costs, and avoidable emergency utilization. Telehealth access points are valuable because they're one of the few interventions that can address several of these barriers at the same time. They're not going to solve every problem, but they can reduce the transportation burden. They provide connectivity. They offer privacy. They support digital navigation, and overall, they just create a local bridge to remote providers. So I put together these quick access indicators just to show why this matters across our 3 states. As you can see from the rural population, we all have significant rural populations, especially compared to other states. A lot of our households here, so we have good internet adoption. That's one thing I wanted to bring up. Really great, 90% internet adoption. But as you can see, that the wireline adoption is going to be much shorter. Um, while this is something that's improving thanks to the broadband offices across the country, it's still an issue because the wireline is going to represent the most stable telehealth visit. It's the best, most reliable service. So that's really the metric that we look at for reliability. When you're thinking about some of the gaps, so between that 72% and the 90%, um, the reason for wireline not being as spread out across is it can be more expensive to build um, and reach out into some of these highly rural areas. We have a lot of open space. We have really hard ground, granite. There may be having to go through forests. Sometimes it's just not uh, possible to get it out into those areas. But then also something I want to bring up too is affordability. Always a major concern. Um, if we could solve affordability, this would mostly disappear. Most people would probably be on wireline. But then also, so internet aside, um, there's also not a lot of physical options in these rural areas. Just wanted to bring up the first shortages because they really show where these gaps come from. There's been a ton of closures. There's a lot of gaps, especially in primary care, mental health care, um, maternal care. There's just gaps, and it's something that's continuing to worsen as well. As you can see from the rural hospital closures, we've all had a lot of hospital closures since 2005, and that's something that's just continuing. Um, so something to remember too, just when looking at these, that rural populations are substantial, provider availability is limited, hospital access is weakened in some areas, and broadband quality is uneven as well. Um, so in that environment, telehealth can help, but only if patients have a place where they can reliably access it. So health inequity maps reinforce that access challenges are not evenly distributed. I really like these because it's kind of a holistic view. They pull in a lot of different factors. Food scarcity. There's quality of life metrics. There's life expectancy. It really just paints a picture. And as you can see, and all three states, that the more rural you are, the worse your health outcomes are going to be. Um, you're just in a much higher risk area because of the things we just talked about. Um, the isolation kind of permeates everything in your daily life in rural areas. One thing to note about these as well is that I like to highlight is that uh, the life expectancy difference in some of these areas can be 10 years or more, and that's very significant. Someone living here in Oklahoma City could live 10 years longer than somebody living the exact, very similar lifestyle out in western Oklahoma or southeastern Oklahoma. Um, it's just a powerful reminder, I think, that geography can shape health outcomes. Um, longer distances, fewer providers, lower income, poorer connectivity, social isolation all contribute to the disparities. Telehealth access points are not going to be a replacement for broader investment because a lot of these problems that we're looking at are systemic. But telehealth can fit into a health equity strategy. Because they create local access where there may not be otherwise be a practical option. So transportation looks different across the three states. Barriers present in each. Missouri has strong urban anchors such as St. Louis and Kansas City, but the rural areas rely heavily on limited regional transit and personal vehicles. Kansas has a highly rural and dispersed population, with transportation often depending on demand response services. Oklahoma is a mix of urban centers and large rural and tribal regions. There's also formalized transportation support, such as NEMT and value-added services that we offer through Oklahoma Complete Health and other similar plans. But the problem is they still face high geographic burden. It can be difficult to find drivers. It can be expensive too. Um, One thing to note is that even with a car, transportation to medical facilities in rural areas takes an average of 31.5 minutes. And nighttime and emergency trips can take significantly longer, sometimes up to 4 hours. When we talk about transportation, we should remember that it's not just about mileage, it's also about time away from work, childcare, caregiver support, vehicle reliability, fuel costs, road conditions, weather, uh, and the stress of traveling long distances for care, or you're just traveling long distances in general. Um, on top of that, increased drive time applies to every aspect of living in rural areas. So this is a compounding issue. If a visit can be safely and appropriately completed through telehealth, a local access point can remove or reduce many of those burdens. Talking about broadband again, broadband availability map shows another important access issue is that speeds are often stronger in more populated counties and weaker in rural areas. So as you move into less populated areas, there may be less wireline adoption, more reliance on satellite, 5G, fixed wireless, or just other technologies. Not all of them are going to be as reliable as wireline, though. Um, but they're still very useful, and some service is going to be better than none at all. Um, but the issue just always comes back to consistency. The telehealth appointments depend on stable video and audio, and a connection that technically meets speed thresholds may still create problems if it's unreliable, if there's high latency, or prone to interruptions, which other types of technologies can introduce those. Um, and this, I think, is where community anchor institutions play a really important role. Libraries, schools, clinics, community centers already have strong connectivity than a lot of the homes in the surrounding areas. Um, and so telehealth access points kind of leverage that infrastructure to create more healthcare access. And connectivity alone is not enough. Uh, as you can see from the slide, surveys from NTA show that 10 to 15% of people in Oklahoma, Kansas, and Missouri did not use internet due to concerns for online safety, lack of know-how, and perceived irrelevance to daily life. It also notes that approximately 33% of American workers were found to have limited or no digital skills. And it also points out that educational attainment is one of the strongest predictors of digital literacy, with the example that people with bachelor's degrees are 7 times more likely to own a computer than somebody with a high school diploma. I bring up that one mainly because, affordability is a concern. There's a strong tie between income and educational attainment, and with how digital skills tie into that, I think it's very clear. It's very easy to draw the line too between affordability and digital skills in that regard. So this is critical for telehealth. If somebody can't navigate a patient portal, access an email link, troubleshoot audio and video, or understand basic platform instructions, then the presence of a telehealth service doesn't automatically create access. Digital literacy is part of healthcare access, and that's why digital navigators are so important. They help turn the theoretical access into actual access, and they can assist patients with non-clinical steps that often determine whether a visit succeeds or fails. So what do these indicators imply? So first, there's a few physical options in many areas. Health professional shortage areas and hospital closures reflect limited availability, which has been a worsening trend for over the last 2 decades. Second, rural challenges compound one another, including long travel times, worse health outcomes, and poor digital literacy on average. Third, internet adoption may be high, but lower wireline use, affordability gaps, and poor digital skills create digital access challenges. And overcoming these barriers takes multiple, sometimes overlapping solutions, but one that can target all 3 are telehealth access points. So telehealth access points help because they address multiple barriers at once. So for transportation, local telehealth hubs can eliminate or shorten travel to distant providers. For provider shortages, they can connect patients in shortage areas with remote doctors and specialists. For connectivity, they offer high-speed internet, devices, and power for those who lack them at home. And for digital literacy, staff or digital navigators can help patients use devices and platforms. For privacy, soundproof, soundproof booths or private rooms can create confidential environments, while device settings can help ensure personal data is not stored on shared equipment. And then there are just some examples of these that I've applied. Um, there's a lot of different programs like this rolling out in every state, and they're all like we looked at before. They're all going to look a little bit different. But one example I like to bring up. So the Florida Extension Office saved about 5 hours travel time and 324 miles per specialty visit. That's obviously significant. Um, and then New Mexico Library is listed saving patrons up to 15 to 38-mile trips to the nearest clinic. So the slide's also going to highlight examples in Texas, Oklahoma, and Arizona where older adults or library users completed telehealth visits with assistance, including help with email access, portal login, video setup, training, and hands-on support. The key point is that telehealth access points are not just about technology. They're about creating conditions that allow telehealth to work for people who would otherwise be left out. All right, so the last thing I wanted to cover as well is if you were interested in this and you have questions, if you want to try to roll out your own project, where do you start? Well, I just wanted to, I like to bring up these 5 questions that have people consider. So first is, what are your funding requirements? Funding requirements matter because they may determine the kind of space or equipment is allowable. In the Oklahoma example, we had the relevant requirements included no permanent fixtures and ADA access. So those requirements shape the type of telehealth access point that can be installed. It's going to be something you have to work around. Need also matters. So poverty persistence, rurality, and lack of providers were major considerations for us. But need alone doesn't make a site viable. So partners and your partner recommendations were very important because local partners knew, they knew which sites had enough space, enough staff capacity, enough connectivity, and enough community trust to make a project successful. Project limitations can also affect viability. ADA compliance eliminated some sites that were unwilling or unable to make needed accommodations. And then space requirements also matters, especially when the goal was to include enough room for a wheelchair or indicate a caregiver. And then finally, site buy-in is essential. Even a technically good site may not succeed if staff, leadership, or the community don't understand the value. In many cases, building buy-in requires repeated conversations, addressing concerns, and making a clear business case. So that was all I have. If you have any questions, if you're interested in rolling out a telehealth access point, please, or if you just wanted to throw around some ideas on it, please reach out either to Telehealth Resource Center or to myself. We can get you hooked up with partners and help you build up this program. So yeah, thanks for joining me today. Have a good day.